Hi, everybody. Welcome to Blood Education Baristas. My name is Daniela Hermelin, and I am the CMO of Impact Life and Assistant Professor of Pathology. And I'm so glad that you joined me today. We are bringing you piping hot transfusion news, and today is going to be a great topic, something I particularly have a passion about, and that's thinking about what we use as transfusion indicators today, meaning what exactly do we use as clinicians or healthcare workers to decide when a person requires a red cell transfusion? And I'm sure all of you are thinking, well, we use the hemoglobin. And so I'd like for you to take a step back today and be thinking about what exactly you use. And I'm going to bring a guest on, an expert, someone who I really think highly of, and that's Dr. Aaron Hess, who is going to be speaking to us about a new concept of thinking about what we should be doing when we think or consider a patient needing a transfusion. And that's talking about the oxygen extraction ratio. So without further ado, I'm going to bring on my friend, Dr. Aaron Hess. Hi,
Hello.
thanks for joining this morning. Aaron, I really appreciate it. I'm really impressed by your work. And I think we should start off by saying that you are an anesthesiologist.
I am.
Yeah, and that's kind of rare in our community, not so much. And so, can you tell us a little bit about your journey and how you got involved in transfusion medicine?
Sure. Um, Thank you so much. So my name is Aaron Hess. I'm an assistant professor in the departments of anesthesiology and pathology and laboratory medicine at the University of Wisconsin in Madison. I was exposed to transfusion medicine very early in my life through my father, who is also a transfusion medicine doctor. And when I was in medical school, I really enjoyed transfusion, was always fascinated by it, was interested in trauma epidemiology. I had the fun of being a medical student at the University of Maryland in Baltimore, where the R. Adams Cowley Shock Trauma Center is. And at the time, R. Adams Cowley was really a leading light in terms of the development of balanced hemostatic resuscitation and trauma. They were a major site for the proper trial and a very successful recruitment center for that. They were doing neat things like keeping platelets in a shaker in the trauma resuscitation unit so that they could do really early platelet transfusions and just doing neat things. And it was hard not to be interested. And then when I decided, originally I thought I wanted to be a critical care doc. And I did my PhD research in epidemiology in ICUs, and then discovered that I had no ability to do pulmonary clinic, and quickly realized that I couldn't go down the general internal medicine pulmonary critical care route because I was just going to be awful at it. And I was feeling kind of bummed about this. Geez, do I have to put up with all of this stuff in order to become a critical care doc? And then when I was doing my PhD, I watched an anesthesiologist do an urgent reintubation in an ICU at shock trauma. And I thought, I want to do that. That looks like fun. And I talked to the anesthesiologist afterward, and we had a nice, lovely, nerdy discussion about beta receptor physiology outside of the room. And then I ended up shadowing him, and I ended up doing this sort of official longitudinal clinical work with him. And I just got exposed to all of these wonderful people who did terribly practical things with their hands, but then would sit and talk to you about pharmacology and physiology. And I can still remember very vividly as a young as a young medical student, talking to a woman named Karen Hong, who's now the residency program director at the University of Maryland, or at least was the last time I checked, and talking to her about the difference between oxygen tension and oxygen carrying capacity in patients who are breathing greater than 21% oxygen or greater than room air oxygen. And that you can turn somebody's FiO2 up to 100%, and it is not going to meaningfully alter their oxygen delivery to tissues, because hemoglobin is such a much more efficient oxygen carrying system than water is. I can still remember having that conversation with her, sitting in an operating room at shock trauma as a medical student. And then I went off and I became an anesthesiologist. So I went into anesthesia because I loved it. And I thought, great, I'm going to be an anesthesia critical care doc. And um, I, as an anesthesiology resident, I asked if I could do a transfusion medicine elective. And they said, sure, what's that? And so approached our, I approached our, I approached the chief of transfusion and said, hey, could I do a 1 week elective in your program? And he said, sure. And so I kind of invented my own 1 week elective and immediately loved it and said, this is really cool. And within a month or two, went back to the program, went back to the division chief and said, hey, I've read the AB path rules. It says I can do this. Do you have any objection to me applying? And would you be supportive if I applied as an anesthesiologist? And he said, oh yeah, this was Dr. Tom Rafe, who sadly who was our division chief for some time and just retired. And he said, absolutely. And everybody in the division was really supportive of this. And so instead of becoming a critical care doc, I ended up going into transfusion, and I did my transfusion fellowship here. We had already filled the year after my anesthesia residency. So to fill some time, I happily did a year of liver transplant fellowship here. And we have a anesthesia liver transplant fellowship, and I did a year of that. Then I did a year of transfusion medicine here, and took my boards in 2020. And since then, I've happily split my time between doing liver transplant anesthesiology and transfusion medicine here. And
What what an incredible journey, truly.
it's been a wonderful way to divide my time and support my interests in resuscitation and transfusion practice. And it's really a lot of fun getting to be a very bedside oriented transfusion medicine doc and also being an anesthesiologist who has a lot of really intimate knowledge about something that anesthesiologists do a lot. We hang more blood than anybody else, and we're the only doctors who routinely touch blood bags and spike them and give them to people. But there's still a lot of lack of education and some, you run into funny superstitions about blood just that comes from people not being well educated about it in the anesthesia world.
Mhm.
And it's been wonderful for my own satisfaction to learn more about that, and a real pleasure to share that with people when I get asked to.
Mhm.
And it's been I've been doing this for 4 years, and it's been huge fun. There are a few other people out there who do it. Um, I know of at least two other young colleagues of mine, about the same age as me, roughly the same amount of time out, who are
Mhm.
dual trained in transfusion and anesthesiology. One of whom, like me, is actively practicing in both fields at Stanford. Uh,
Mm.
I met somebody else who's up in Canada who's dual trained, and of course there's a couple other notable figures in the transfusion world, people like George Despotis at WashU,
Yes.
who was a cardiac anesthesiologist and then went off and did transfusion. And I believe, I have been told, I've never actually had the pleasure of meeting him, but I've been told he does exclusively transfusion medicine now.
Mhm. Mhm.
But so there's a tiny community of us, but we are out there.
Yeah, I think it's really phenomenal. And I love the fact that you took, like you said, your inner strengths and talents and carved a way for yourself that made sense for you. And, taking your profession in your hands, saying, what do you think about this? Would you allow me to do this? And of course, yes. And so you really serve as a mentor for others to kind of just find that path, your passion. And like you, when I train residents or med students, sometimes I say to them, you'll learn as much as what you want to do by what you don't want to do, right? So you said during your journey, you're like, no way, I could never do this. But
Yeah.
then you were so attached and passionate to this other area, and that kept you driven to do it.
Well,
And
at the time, I
yeah,
think it sometimes felt like I was just having to be honest about what I couldn't hack, and repeatedly deciding to choose the thing that I was genuinely interested about and made me happy, and
mm,
not the thing that I thought I wanted to do beforehand, which was kind of how I got to with critical care. I realized it was more
Interesting.
just because there were all these intensivists I knew who I really admired, but it
Yes.
actually really wasn't for me when I spent a lot of time doing it.
Yes, I do want to drive home the point, and I actually felt I learned this more during COVID than any other time, and that's the role of the anesthesiologist as a gatekeeper of transfusion practice. And I say that I learned it more during COVID than any other time, or I want to say that I really had that relationship and it was super close and super intense during that time, and that's because there were these transitions where the blood supply was low and I had to have a very good communication with those that needed to know what our inventory was and vice versa, who was coming into the hospital.
Mm-hmm.
And so I was best friends, and I still am, but with the head of anesthesiology because we were constantly in touch with each other.
Yeah.
And like you said, and I don't think many people know this, anesthesiologists are the ones that are actually spiking the units in the OR. They're the ones transfusing those units. And perhaps it's their surgeon who has an awareness, perhaps they are ordering the blood ahead, but it's
Yeah.
the anesthesiologist who's really intimately involved in that patient, specifically in the transfusion of the patient.
Yeah.
Yeah. So, you talked about superstitions, and I'm not sure we're going to really talk at great length about superstitions, but I do want to talk about maybe some old practice and how we can move our practice forward.
Yeah.
And I became super interested in this area recently when we, as a blood center, began to collect what's called a low volume red cell unit,
Mm.
which is simply an undercollected unit.
Right.
Basically, you have a bag of blood and a donor is sitting on a chair, and often that donor at the end of the collection may faint or have presyncope symptoms. And it's unfortunate, but if they don't collect enough, then that unit gets discarded,
Mm-hmm.
unless there are certain provisions put in place where blood centers can actually collect what's called an undercollected or low volume unit.
Mm-hmm.
And so we began to collect them because we don't want to discard something that could be used.
Yeah.
But it got me thinking about what's in the bag. And we call these, small but mighty. So you have a unit of blood. It's a little bit smaller than what we call a standard unit. But when I was researching them, because I had an IRB study that looked at patients who received these low volumes, how did their hemoglobin increment from them?
Right.
Okay. And I compared it to standard units. But then I thought, does this even make sense? And what I found was every patient was a little different, whether their size of them was different or their indication for the transfusion was different.
Yeah.
And I thought the donor who's donating the bag has a different hemoglobin, although we have the very similar hematocrits at the
Right.
end of the day of those bags. But what is the dose of a red cell unit?
Yeah.
How do we do that? And is really the hemoglobin the best way that we're measuring or predicting or even understanding if a patient requires a transfusion?
Yeah.
So that's my background into this, got me down the rabbit hole. And when I read your article, I was like, hallelujah. This makes sense. And how can we move it forward? So before we talk further, there might be people on the call listening in to say, what is she talking about? What did you bring up that doesn't exist today? So can you tell us a little bit about and get us to the concept of an oxygen extraction ratio?
Yeah. Well, I think where I got to with this was, I can still vividly remember, talking about being a medical student, hanging out on critical care wards and just sort of standing around being fascinated by people. I can still remember, this would have been 2000. I'm going to say it was 2009. Standing on a medical critical care unit at the University of Maryland, listening to an ICU doctor who I would later ask to be on my PhD committee. And he did, and was a wonderful mentor for me at the University of Maryland, Giora Netzer. And listening to Dr. Netzer talk to his medicine residents and fellows about the TRICK trial. Now, this was 2009, so this would have been a decade after the Trick trial was published in the New England Journal of Medicine. And yet it was clear that a decade later, at that time, the whole concept of restrictive transfusion practice had not penetrated well into practice. And people were still constantly transfusing patients blithely up to hemoglobins of 9 and 10 and just keeping them there, not because anything in particular was going on with them or that they were justified because they had active ACS or they were worried about particular malperfusion syndromes, but just because 10 or, hemoglobin of 10, crit of 30 was what you did. And there's
And just a pause, Aaron, can you just referring to those in the audience listening, the trick trial was one that was looking at restrictive
Yeah.
versus,
So this was Paul
go ahead.
Hebert's trial that was done primarily primarily in I think Montreal and other Quebec and Ontario blood centers, where they randomized mixed medical and surgical ICU patients to get who had hemoglobins of less than who came in with hemoglobins, I think less than 9 was the criterion, to get randomized to a transfusion goal of greater than 7 or greater than 10 grams per deciliter. And
So restrictive versus liberal
which we've now come to
transfusion.
interpret, as the kind of restrictive versus liberal, the 7 versus 10 concept. Or think about it another way. Do we let people have moderate anemia or severe anemia? With transfusion, and the lack of meaningful difference in outcomes at 30 days between those two arms, which has been interpreted many, many different ways. But what stuck with me about that is that it's not that one or the other was obviously worse or better. It's that they didn't have a meaningful difference between those two hemoglobin levels, and that we default to restriction, because if we can't find a difference, we might as well not expose them to the blood and use a precious resource. This sounds completely rational. But
Right.
I was struck almost immediately by the fact that there seems to be a huge range of hemoglobin values across which nothing very much happens. And yet we spend a huge amount of time arguing with ourselves and each other about what's the right hemoglobin for somebody to be at, when we have a complete absence of clear benefit or harm across a very wide, medically common range of hemoglobins. And so you ask yourself, what's wrong with hemoglobin in terms of the calibration and discrimination of hemoglobin as a transfusion trigger? And why should that be? Because hemoglobin ought to be really important, because hemoglobin is the primary determinant of oxygen carrying capacity in the blood. There's two ways for the blood to carry oxygen. You can dissolve oxygen in water, and in the water, the aqueous fraction, the liquid fraction of blood, or you can absorb, or it can be bound by hemoglobin molecules. And hemoglobin molecules are, somewhere between 100 to 1,000 times more efficient. If I'm remembering the numbers correctly, it's many orders of magnitude more efficient binding than, or many orders more efficient carriage than dissolving in water. And so this is why when you use the oxygen carrying capacity equation that we all get exposed to in medical school and then gratefully forget, is why it's so much more, the hemoglobin level is so much more important. And I thought, so why shouldn't it be the primary determinant of where we benefit from a transfusion? And yet there's this huge range of hemoglobins across nothing very much seems to happen clinically. And why is this? And we talk about 7 versus 10 a lot in the literature, and the most recent AABB guidelines on red cell transfusion that were just published last year talk about restrictive versus liberal practice as generally being thresholds in the 7 to 8 range versus ones in the 9 to 10 range. And yet I'm going to I'm going to guess that if you talk to most transfusionists, they'd probably agree that between 6 and 10, most people don't have any meaningful alteration in their tissue oxygenation on average.
Mm-hmm.
And why should that be? That seems really weird that there should be a huge range of hemoglobins across which we can't detect any differences in outcomes as a result of tissue oxygenation.
Mm-hmm.
And so that just kind of puzzled me for a really long time. And then
Yes.
I think I started to think about it in terms of, well, is it really that we can't detect those differences? Is it really that there isn't any difference, or we just can't detect that difference? Because inevitably, when you do clinical research, you have to get averages across of populations. And it's not that there
Mm-hmm.
isn't
Mm-hmm.
any meaningful difference, is that there's probably people in that range who would benefit from a transfusion, and people
Mm-hmm.
who would improve tissue oxygenation following a transfusion, and people in
Right.
that range who their tissue oxygenation wouldn't change after a transfusion. But when you're
Mm-hmm.
dealing with populations, groups in a randomized trial, we can't distinguish between who will benefit from a red cell transfusion and who won't based purely on their hemoglobin level. And we've got to find some better way of
Mm-hmm.
distinguishing between patients with moderate anemia who will and won't benefit from a red cell transfusion.
Mm-hmm.
And that was kind of what launched me onto this idea of thinking about it.
Okay. I want to take a step back and get to a basic concept, which is hemoglobin in itself. And so maybe this will help us to go through the pathway, and I'm using this pun intentionally. So when I talk about hemoglobin with my med students or residents, I say that I want you to think of the red cell as a FedEx truck, and that the hemoglobin is a carrier that's got 4 seats in the FedEx truck.
Mm-hmm.
So sort of, and you got your oxygen, that's your people sitting in the hemoglobin, what's in the FedEx truck. So right now, all we do is measure, we break open the FedEx truck and we measure how much hemoglobin would be essentially driving around the body. And that's all we do. What you're saying is that, people have different amounts of maybe FedEx trucks, different amount of hemoglobins in their FedEx trucks or UPS trucks, excuse me, any carrier. So we're not though talking about how bumpy the road is. We're not talking about the roads themselves or about how that oxygen is delivered into the tissue or
Right.
who's handling them. And are you saying that has consequences, not just,
Absolutely.
yeah, yeah.
Just because your local if we're going to I like this metaphor. Let's run it. Just because your local postal carrier has lots of trucks
Mm-hmm.
doesn't mean that that just adding more trucks is going to increase deliveries to your area. Roads can be shut off, or roads can be bad.
Mm-hmm.
People could people's post office people, in the sense that you can have differing perfusion in different tissue beds, and simply um, increasing somebody's hemoglobin and improve, by increasing their red cell mass and improving the availability of carriage, doesn't mean that those oxygen molecules are going to penetrate to those tissue beds if, as it were, the roads are closed off. You can add all the trucks you want, and if you don't have a road to that house or the road is shut down, you're not getting deliveries to that area. Similarly, there may be people who don't need that many deliveries, who aren't ordering things constantly off of Amazon and don't frankly need to have that degree of delivery, whereas there's other people who are desperate for constant deliveries, or they're trying to run a business and they're ordering things in and out. There can be different demands in different tissue beds. And not all patients, it seems reasonable to assume that not all patients who have what we would consider to be moderate to severe anemia will have the same requirement for oxygen at the tissue level, just because their available delivery system doesn't have as much carrying capacity. You can have, and just to put it at a, or you can have a situation where it doesn't matter if they have demand or not, because simply adding red cells isn't going to improve local tissue oxygenation. Think about sepsis, where frequently in sepsis we have shunting of circulation through tissues. So you may have inadequate local tissue oxygenation, and because of changes in local tissue perfusion, where actual flow of blood through tissues is restricted because of dysregulation of the microcirculation in the setting of sepsis. And it doesn't matter how many red cells you add to the circulation, they are going to bypass those tissues. And
Mm-hmm.
so in that case, transfusing to we can think about things like, we've had randomized controlled trials of red cell transfusions in sepsis based off hemoglobin, and it doesn't help to give more red cells to patients who logically need to improve their tissue oxygenation because they're in distributive shock, and they ought to need more oxygen to their tissues, but transfusing them to a higher hemoglobin level doesn't improve their clinical outcomes.
Mm. Well, you've definitely sold us, or I've drank the Kool-Aid. So if we have if monitoring hemoglobin, or at least using it as a predictor for transfusion indicator,
Mm-hmm.
what should we be doing? What are the other methods? And
Yeah.
if there is another method, is it best used for a certain population, or could be applied to all people as well?
So the answer is, we don't know the answer, but there are a bunch of candidates that have been explored as people have looked for what are typically loosely regarded as either alternative, or some people call them physiologic transfusion triggers. And these include things like the oxygen extraction ratio, which I've become interested in, local mean tissue oxygenation. So typically that's something that you get by doing side scatter oximetry using systems like NIRS, near infrared regional spectroscopy. I think that's how it's called. Oh Lord. Now we're live on a on an interview, and I'm worried about my acronyms. But things like NIRS, cerebral perfusion, using blood lactate levels as an indicator of tissue malperfusion. A lot of things have been investigated, and there are some really neat articles that I've read where people have gone through these things systematically. The one that really caught my eye when I became interested in this idea was the oxygen consumption, measurable oxygen consumption. So arteriovenous oxygen consumption, either measured as absolute arteriovenous gradients or measured as oxygen extraction ratios. And the reason I became interested in this was I read this very interesting observational study, which was done by a group in Italy. By the first author's last name is Fogagnolo, where they looked at patients who were undergoing cardiac surgery, post cardiopulmonary bypass. And so these are all heart surgery patients. So they all have jugular lines, with many of them have Swan-Ganz catheters in, and they've all got radial arterial lines. And they were measuring radial arterial oxygen content using an arterial blood gas, and they were measuring sometimes jugular, sometimes central pulmonary artery venous oxygen content, either as saturations or as absolute oxygen tensions, PaO2s and PvO2s. And what they found was that, and all of the patients who they looked at in this observational study had at least moderate anemia. So they had hemoglobins of less than 10. And what they found is that the patients who had, using those saturation measurements that they invasively measured, those who had wide oxygen gradients or high extraction ratios, who got transfused, did better by the measure of 90-day mortality. And patients who had narrow absolute oxygen differences or small extraction ratios who didn't get transfused did fine, even if they were moderately anemic. By contrast, the ones who had wide extraction ratios or large extraction ratios or wide arteriovenous oxygen differences who didn't get transfused did badly, had higher 90-day mortality. And the ones who had small oxygen differences and low oxygen extraction ratios who did get transfused also did badly. So it seemed to be able to. Now, this has huge caveats. This is an observational study. These patients weren't randomized. There are huge opportunities for confounding in a study like this. But it was really, really piqued my interest to think about the question of whether or not looking at tissue oxygen extraction might be a feasible way of discriminating between patients with moderate anemia who actually would benefit from additional red cell transfusions and those who won't. Now, oxygen extraction ratios or absolute oxygen differences in this case, there's a lot of fine detail in there, because although we presume that every arterial oxygen saturation and oxygen content is the same everywhere in the body, because the blood that comes out of the heart freshly oxygenated from the lungs goes down the arterial tree, and it's pretty much the same everywhere because it gets there quickly and not a lot of oxygen absorption happens in the arterial system. And so pretty much whether you're measuring it in the finger or the brain, arterial blood is the same everywhere, pretty much, in terms of oxygen content. Once it's passed through a capillary bed and it comes out the other side as venous blood, all venous blood, on the other hand, is different. Peripheral venous blood is very different in terms of its oxygen content than, say, jugular venous blood having come out of the brain, because peripheral perfusion demand on oxygen saturation in the peripheral system is pretty variable depending on what the person's doing, how sick they are, if they have regional shunting, whereas it's less variable across the brain, depending on what's going on. And just different organs have different demands at different times. Your heart or your kidneys may be doing more or less depending on what you're doing. And we just know that from empirical studies that average extraction and arteriovenous oxygen differences vary in different tissue beds on average, regardless of what they're actively doing or not actively doing at any given time. So it matters where you measure the venous saturation because you get different oxygen extraction ratios. But these authors were either measuring systemic oxygen extraction in the heart or at least transcerebral across the brain if they were getting the saturations from the jugular bed. And that was interesting because the brain is, hopefully nobody disagrees with me, let's say it's the second most important tissue bed in the body after the heart, in the sense that if the heart doesn't get oxygen, things stop pretty quickly. But if the brain doesn't get oxygen, there's not much point in things going on if you have an anoxic brain. And it seems that our cardiovascular system does a huge amount automatically and reflexively to prioritize cardiocerebral circulation over every other tissue bed. Even the, as say, the gut, the splanchnic beds, the kidney, the renal perfusion beds. So the fact that they were measuring things, at least in the cardiocerebral circulation, seemed really important. So I got really interested by this paper. I read some other papers that seemed to suggest that this was a legitimate area of interest, The problem is it's hard to get excited about this because they
Mhm.
were dependent on invasive measures of venous saturation, because they
Right.
had to have jugular lines. You can get these patients all had radial arterial lines and they were getting arterial blood gases in there. But a normal commercially available pulse oximeter is
Mhm.
an incredibly accurate way of measuring arterial oxygen saturation and content. Whereas we don't have a good non-invasive way of measuring venous saturation or oxygen content. And they were totally reliant on jugular lines, and very few patients who get transfused red cells have invasive lines in there. And no serious person is going to propose, let's completely redefine how we give red cells to people, and we're going to start by putting central lines in everyone. It's just not going to happen.
Right.
It is genuinely
Right. Exactly.
possible. So the only way that oxygen extraction or would ever be a usable transfusion trigger for your average patient would be if you could measure venous saturations non-invasively. And at
Mhm.
this point, about 3 years ago, I gave up on this line of inquiry because I couldn't crack that problem myself. And I just sort of said, I guess this wasn't a very good idea, Aaron. And I kind of gave up on it and I just put it on the back burner in my head.
Okay, but I have a feeling that something happened in the last 3 years.
Well, I kind of got, it was one of those ideas that kind of stuck around, and I tried other things, and I looked at, and I every so often I'd look for papers and see if anybody had come up with a way of doing this. And about 2 years ago, I came across a paper where where a couple of biomechanical engineers and an intensivist had become interested in the question of whether they could measure oxygen saturations non-invasively. And they had developed a really accurate system for measuring non-invasive saturations, just using a modified pulse oximeter in the finger. And they'd done all this beautiful work where they described this method. And this was a paper that was published by Musabir Khan, who was a graduate student at the time at the University of Canterbury in Christchurch, New Zealand, and his mentors, who were a couple of biomechanical engineers and an intensivist at the Christchurch Hospital. And what they did was they put a digit blood pressure cuff. It's actually a blood pressure cuff designed for taking either finger or penile blood pressure measurements. And they put it on a patient's finger, and then they put a pulse oximeter that they'd modified so that they had so that they could get raw data out of the pulse oximeter. And they put it on the patient's finger. And what they did was they then introduced artificial venous pulsations by gently pulsing the finger using that blood pressure cuff out of sync with the arterial pulses and at a frequency closer to the respiratory rate, so like 6 to 10 times a minute. And then they were able to detect variations in the absorbance of red and infrared light in the pulse oximeter that they knew were in sync with the pulses they'd done in the cuff. And so they knew that those must be differences in absorption in the venous compartment. Now, I should mention that the reason that you can't use normal pulse oximetry to detect venous saturations is because normal pulse oximetry relies on arterial pulses to distinguish arterial signals from capillary and venous signals. And so we can't normally disentangle capillary and venous signals, just arterial ones. And the genius of this is that by forcing fake pulsations in the venous system, they were able to create a distinguishable venous system. I'm eliding over a huge amount of really clever work that they did in terms of signal processing and understanding how to do the signal processing work, and really lovely jobs doing blood gas analysis, because they put arterial lines and venous IVs into all of their healthy test subjects so that they could very carefully measure these against invasive signals. And they did a lot of really beautiful work with, differential arm positions and inducing false tissue ischemia temporarily using upper arm blood pressure cuffs, just to make sure that they were getting real signals that they could perturb and then watch them come back to baseline. But they eventually said, no, we can really accurately and precisely measure venous saturations in the finger. And this just was amazing. I said, oh my God, they've cracked it. And I wrote them an email and I said, hey, have you done anything with this? And they said, well, we thought we were building a new sepsis monitor and it didn't work for what we intended it for. And Dr. Khan graduated, got his PhD, and went off and got a job in the tech industry. And when we put the device on a shelf, why do you want to know? And I explained to them this idea that I had, and they said, we think we can build you a new one. And actually, honestly, we think we can build you a better one. By the way, would you have any interest in measuring these things in the jugular vein? Because we worked out how to do that too. And that was just sort of like somebody, sort of casually mentioning that they'd worked out how to turn lead into gold.
For you, for sure.
A side process of the fact that as a side process in something else. And I said, actually, that's much more interesting, because I was thinking, well, I mean, it's really cool that they've got peripheral venous signals, but something tells me that peripheral oxygen extraction isn't going to be nearly as important as transcardiac or transcerebral oxygen extractions. And so we recently were fortunate enough, we got an AABB Foundation early career. I was awarded an AABB Foundation early career research grant.
Congratulations.
Thank you. That I wrote with the Dr. Chris Priddy and Dr. Jeff Chase, who are the two biomechanical engineers at the University of Canterbury who did this work. We've been working with, and I've had the really fantastic mentorship of Dr. Jeffrey Carson at Rutgers, who's helped me with thinking my way through some of this stuff, and is just one of our living experts in red cell transfusion. And we've got a just fantastic graduate student, Jordan Hill, who's a PhD student in mechatronics, which is and biomechanical engineering at the University of Canterbury. And Jordan's been doing some really beautiful work taking they had a proof of concept jugular sensor, which still has yet to be tested in vivo in humans against invasive samples. But
it's a similar concept of trying to apply pressure and
so that's the really amazing thing is that what Jordan has done is she has worked out how to capture carotid and jugular venous pressure signals, because the jugular veins are close enough to the heart that you have distinguishable, as we all learned in medical school, jugular venous pulsations. Well, jugular venous pulsations, although they are in sync with arterial pulsations, are morphologically distinct, and in fact are morphologically much more complicated than arterial signals. So they're easy to distinguish if you have if you've built your sensors correctly. And so Jordan, by doing some clever things, by modifying the sensors so that they can resolve multiple signals, your classic arterial pulse ox is a unidimensional sensor. It just tells you through this entire tissue bed in a single dimension what's going on. Jordan's built really neat sensors that can actually resolve things in 2 dimensions and can simultaneously disentangle arterial and venous signals. And the electronics and the signal processing are terribly clever, but fundamentally she's doing something that once she's done can be built for pennies. And with the right software, you can non-invasively measure carotid and jugular signals non-invasively. So we're getting close to the point where we might be able to start doing some very limited in-human testing, and eventually someday step this up to the point where we could actually start looking at how it responds to transfusion.
Unbelievable.
So,
and would you say that the methodology is using ultrasonography?
No, it's all light.
It's
the same basic concept as pulse oximetry. So back in the about 40 years ago, the basic concept when pulse oximetry was invented, and I apologize, I'm forgetting the name of the Japanese engineer who developed the basic work behind pulse oximetry. In pulse oximetry, you shine light at two wavelengths through a tissue bed, typically around 660 and 940 nanometers. And you look for differential absorption along those two wavelengths. And if you know against you can look at the differential absorption across those two wavelengths and compare it to a standard curve to say what proportion of hemoglobin is oxygenated or deoxygenated in that tissue bed. And then if you follow the changes across those two absorption spectra over time and look for regular periodic changes at a rate and wavelength and waveform shape that looks arterial, then you can say, those, so at the peak, those must be the signals at the arterial phase. And when that pulse goes away, that must be the background saturation in the capillary and venous beds. And so you can subtract out the capillary and venous signals and know what the arterial signal is. And then you can use that against a standard curve to say, in the arterial compartment, the saturation of hemoglobin with oxygen is 97%, say. You can also do that using, and so typically when you put a pulse ox on your finger, it's shining through the finger end to end. So you have an emitter on one side and a collector on the other side. You can also do this through side scatter, where you have an emitter and a collector side by side. And we've probably all seen or in ICUs, sometimes we can't get a good signal through a finger. So sometimes we use the earlobe. Sometimes, though, we can do it on the forehead by side scatter. And so you'll sometimes see ICU patients where we have difficulty because their peripheral compartments are so clamped down because of their disease process. You can put a side scatter sensor. So instead of going through a tissue bed, the light bounces on and off. And you're still doing the same analysis, looking for periodic pulsations, but you can get arterial saturations by side scatter. They're called transflectance sensors. But the basic idea is the same.
Well, it sounds like we're really close to something, but knowing your legacy, is this something that your son, your grandson, I know your father was a champion, like, are we, Hess Jr.?
Well,
and is our community
not
ready?
My son is an, I don't know. I mean, who knows? I do have children. I have a son who's 8. I have a daughter who's 10. My son is an amazing human, is intensely creative, volcanically creative and artistic. My daughter's really cerebral. If I had to guess if either of them were going to, my wife is also a physician, and we sort of joke that, physicians begetting physicians is sort of a form of intergenerational violence. And we sort of joke, like, what can we do to prevent our children becoming doctors? And the answer is nothing, because people get called to it. At a guess, I'd say that my daughter is far and away the more likely of the pair to become a doctor. And she's terribly mechanical and process oriented. So, if she went off and became like, a vascular surgeon, it wouldn't surprise me. But who knows? I do think, though, that, we're the kind of work I'm involved in, we're miles away from being able to prove any clinical utility of this idea. I just think that, we need to, and I don't think this is at all an original idea. You get 20 transfusion doctors around a table. I think a lot of them will accept the idea that we've wrung as much precision, discrimination as we can out of hemoglobin as a transfusion trigger, and we need something better, but we don't know what it is yet. And to me, this is just the most interesting, promising idea out there. And we have an engineering approach to it that might allow it to be done non-invasively at the bedside anywhere in the world. And that's the other exciting thing for me about that is, you can go into Walmart or Target right now, and you can buy a pulse oximeter for $40, and they're good pulse oximeters. The basic, and that's, to be honest, there's a big profit margin in there. The actual cost of the electronics is minuscule, truly cents or $1 to build a device like that. So with something like this, there's the promise of being able to build a device that anybody anywhere in the world could have access to improve transfusion therapy anywhere. And so it seems to me that although we have a long way to go in terms of proving the clinical utility of this, it's worth trying because the end point is something that would be cost effective and could be done anywhere. And that's really important to
Yes.
improve transfusion practice.
Yeah. I'm very much involved now in pre-hospital transfusion implementation and thinking about, providing blood products to patients outside of the hospitals. And our EMS partners are doing an amazing job. And like you're bringing up that this could be another tool that people could use. It's a very simple tool to understand. And I think it could also not only provide better access in any type of situation,
Yeah.
but it may also help us to understand dosage also more.
Yeah, and that's kind of the
Yeah.
other interesting thing is this has a dosage aspect to it, which is, and again,
Yeah.
we're theorizing way ahead of our data, which Sherlock Holmes would tell us is a sin. But let's pretend for a minute that we can make this work as a device. And then let's pretend for a minute that we've proved that it does improve our understanding of who does and doesn't benefit from a transfusion. It also suggests that because you could just sit there with the sensor on somebody, in theory, if you transfuse them, you ought to see the gaps ought to narrow, the oxygen extraction ratios ought to drop.
Right.
And so it ought to be able to be a way of monitoring transfusion response. And if the gap doesn't drop or doesn't drop much, maybe that person needs more.
Right.
And maybe we'd actually be able to not just say who doesn't just benefit from a red cell transfusion, which right now, for good reasons, because it's what we understand right now, we tend to think of as a very simple thing. Why give 2 when 1 will do? Give 1 unit of red cells and you're done. There are, I think it is, I think we should be open to the idea that there are probably people out there who might need more than 1 transfusion, but we don't know who they are right now. We have no
Yeah, I
ability
agree
to
with you.
identify those people. But this might be able to actually help us identify people who are actually going to need more than a single dose of blood. And conversely, we may be able to start identifying people who, previously we'd say, I actually don't want to transfuse this person, but their hemoglobin 6.5. And best practice says, I got to give this person a unit of blood. There may be people who we can permit to slide lower down. Your warm autoimmune hemolytic anemia patients. Maybe you can identify some of them. I'm making up an example here. Who we could say, actually, the extraction ratio is telling us that right now we can sit tight. We don't have to give this person blood. We're not compromising anything meaningful yet. And we'd like to avoid a transfusion in this person right now. And it could open up. I'm excited at the prospect that it might open up new vistas in diagnosis.
Yes.
For who wouldn't benefit from transfusion.
This is also an area that makes me sad to talk about, but there's also concepts of futility, and I think maybe you're seeing a very wide oxygen extraction ratio. You transfuse, it's not budging.
Yeah.
Is there another component? Are we transfusing and it's not going to do anything?
Yeah. Well,
or at this point, we need to tweak something else to allow for oxygen delivery.
Yes. And also, conversely, you may see patients with narrow extraction ratios who look like they really ought to benefit from a transfusion. And I'm thinking, and going back to the idea of sepsis, in somebody who's shunting blood, it doesn't matter if they're, you could say have somebody who's shunting through a peripheral tissue bed and isn't oxygenating those tissues. They're going to have a pseudo-normal extraction ratio because they're not extracting. It's not that the tissue doesn't want oxygen, but it can't get to it, so the oxygen's staying in the tissue. And in that case, we shouldn't transfuse those people, not because they don't need oxygen, but
Right.
because it's not going to help.
Right.
And
Right.
it's interesting to contemplate that, and the O2 extraction ratio would identify not only patients who don't need improved oxygen delivery, but also those who need it but wouldn't benefit from a transfusion. And this
Yeah.
kind of also cycles back to an idea that continues to fascinate me about red cell transfusion, which is that, a patient with a hemoglobin of 10 and a patient who you transfuse up to a hemoglobin of 10 are not the same.
Right.
And there's an efficacy gap between transfusion and naturally having those hemoglobins. You see people who do big epidemiological studies of outcomes in trauma and surgical patients, and there's dividing.
Yes.
You frequently see a dividing line around a hemoglobin of 11 grams per deciliter, and
Yeah.
nobody's seriously suggesting that we should be routinely transfusing trauma patients up to a hemoglobin of 11. We know we shouldn't, and yet the ones who come in with hemoglobins less than 11 do worse.
I feel like having this discussion and almost this mental exercise for an hour, the statement that you just made, it's saying that there's a difference between a hemoglobin of 10 and transfusing. I think our audience, personally myself, understands this even more so after this discussion. Truly, it's really, there's a major difference between the two, and understanding that gap is very important. We are at the top of the hour, Aaron. I want to leave you with this one last question,
Mm-hmm.
which is, you know, I think that the way we learn about this in medical school could also be really enhanced. And I thought, what happens if we learned in medical school? Because we learn about, the what is it, the different laws and the cardiac output and arteriovenous oxygen differences and all these equations, but we kind of learn them on an island.
Mm-hmm.
But if we learn this by understanding how to apply it in this setting,
Yeah.
or say, I want you to build a machine or a pulse oximeter. You tell a med student for this reason,
Yeah.
because can you imagine what it would be like to be a med student and learning all of these concepts sort of in an experiential manner instead of just, kind of having this thrown at you? Because I remember learning it, but I love learning it now because it all makes sense and it all applies, instead of learning about the oxygen saturation curve and, what shifts it to the right, what shifts it to the left. Okay. And then nothing else after that. But now, really, so can we update our medical curriculum so that we can put what you just said in the last hour to high maximum value? Does that resonate with you?
Oh yeah. I think a lot of what we learn is what we understand, not necessarily turns out to be important. Not perhaps understandably, I think a lot of what we get taught is the things that are well understood, not necessarily the stuff that's actually important.
Yeah,
And I don't know. I think
that's a
that's
good
kind of
point. That's a good
it's kind of
point.
everywhere.
That is a good point. Yeah, just decades of information that we've kind of have and understand, but yeah, to take it to the next level because we do enter into the world of the unknown.
Yeah.
But I feel like asking the med student or trainees or whoever it is the questions first. What are we want? What's our outcome? What are we looking for? And I mean, I'm really inspired by you that as a med student, you are listening to your attending and you're saying, yeah, but why? Or yeah, but does that make sense? And yeah, is there another way? And how powerful that is, because now it's been maybe 15, 20 years of you thinking about a question, of just listening to your attending talking about the trick trial and where it's gone to you today, and how that unraveled is so amazing to me.
Well, I think the only thing I get frustrated is I get frustrated at how slowly it took me to think about all of these things.
Oh, it's incredible. I really enjoyed speaking with you today and actually learning from you. I can't thank you enough for all the work that you have done, your passion, and just keep going after it. I'm very excited to see what's ahead in your future, and congratulations again on the AVB award. It's so well deserved. Any last minute thoughts from your end?
No, thank you so much for having me.
Oh, it's my pleasure. All right. I wish you a wonderful weekend, long weekend, and best of luck in your career,
Thanks
Aaron.
so much, Daniela.
Okay. Take care. Bye.